Hello and welcome everyone to the first of two webinars on diabetes brought to you by the Capital Health Network and the Canberra Health Services. Tonight's webinar focuses on type 1 diabetes, and there'll be another webinar on the 4th of December which will cover the A to Z of type 2 diabetes and medication decisions such as when to transition from oral medications to injectables. So please remember to register for this webinar. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respect to their elders, past and present. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. I'm Dr. Leonie Harcourt, a GP Education Advisor at Capital Health Network. Also with me tonight is the Events Lead at Capital Health Network, Kunal Mohiti, Diabetes Educator Kristine Wright, and Endocrinologist Carolyn Petersons from Canberra Health Services. So just a few things before we start. Question and answers are okay throughout the presentation, so type them into the Q&A box and we'll rudely interrupt the presenters mid-sentence and ask them the questions. So they're quite happy for that. So please, the more questions, the merrier. We like an interactive webinar. And regarding CPD, please fill in the post-event evaluation survey and we'll email you a certificate of attendance after the event. And please feel free to report 1.5 hours of educational activities to your CPD home. And also just a reminder for Health Pathways. Health Pathways, as you're probably all aware, has guidelines and advice on the investigations, treatment and referral pathways for many conditions, including type 1 diabetes. And the login is together or lowercase, and the password is for health, although now encouraging personalized logins so you can register for that on the Health Pathways website. So now over to our wonderful speakers for the night. Our first speaker is Dr. Carolyn Petersons. She's the Director of Diabetes and Endocrinology at the Canberra Hospital, and Carolyn has completed her training in Adelaide before moving to Canberra over 10 years ago. Carolyn has a strong interest in medical education and is currently a national examiner for the College of Physicians and a former director of both pre-vocational training and physician training. As a clinician, she believes in providing high-quality, personal-centered care and works closely with the multidisciplinary team, of which our second speaker is a very important member. So our second speaker tonight, we're very lucky to have Kristine Wright. Kristine is an advanced practice nurse and credentials diabetes educator and holds the position of Senior Nurse Lead of Diabetes and Endocrinology at the Canberra Hospital. She's worked in the adult and pediatric diabetes services for over the past 14 years at Canberra Hospital, and she has a special interest in diabetes and technology in type 1 diabetes, so perfect for tonight. Kristine believes in and works to provide high-quality, person-centered care in a multidisciplinary team. So over to our two speakers. Thank you very, very much for giving up your night to speak to us.
Thank you very much for inviting us both. And as well as people interrupting me, I'm very happy for Kristine also to jump in if there's anything she thinks that we need to add along the way, because we do work very closely together and we can't manage diabetes one without the other. So I was asked to talk about an A to Z of insulin, and I've sort of more broadly encapsulated that to management options for type 1 diabetes. Now, hopefully I can advance my slides. I can. Thank you for having done the acknowledgement of country. Just a brief outline of the talk today. So I'm going to start with an overview of the different insulins that are currently available in Australia and an update on some anticipated discontinuation of available insulins, one of those emails that you may have received and not read, but is actually going to have some clinical implications for us all. I'm going to talk about the different multiple daily insulin regimens that we use, also about insulin pumps, and continuous glucose monitoring, and then the new advances in hybrid closed loop programming with insulin pumps, and just to finish off a little bit on treatment targets for type 1 diabetes. So to start with the insulins, this is now a very old slide, but actually still quite useful to look at the different action times in a non-drug company centric way. So we consider insulins divided up into three groups. The bolus insulins at the top are the rapid acting insulins, which are normally or traditionally given with meals. And really these days, only the, hoping you can see my mouse here, only the rapid acting insulin analogues should be used. So that would be Apidra, Novorapid and Humalog, as well as Fiasp, which I've tucked onto the side, has a very similar action profile to the other rapid acting insulin analogues, but it does work a little bit faster, which can be useful for some patients. Then there's the basal insulins, and these again, there's a lot of old-fashioned ones that are now out of date, but you will still see a little bit of use of Protophane and Humulin NPH. very rarely in type 1 diabetes, but you may still come across it, but predominantly Levemir, which is insulin detamir, and Opdisolin, which used to be Lantus, which is insulin glargine, and the U300 version of that, which is Toujeo. And then there's a range of mixed insulins, which each brand has their own combination of. Most of them are in a 30 to 70 combination, so 30% of a rapid acting insulin and 70% of an intermediate acting insulin. The most common of that you would see would be the Humalog mixes and Novamix 30. And as well these days, and in particular in type 1, quite relevant is Ryzodeg 70/30 insulin. Still 30% of the rapid acting and 70% of the longer acting. They just chose to make life difficult by changing the numbers around the wrong way. But the long acting insulin in Ryzodeg is actually an ultra long acting insulin. So it's insulin degludec, which we don't have as a standalone insulin in Australia, but it lasts more than 24 hours and as a profile really does minimize risk of hypoglycemia. And so that has changed our use of mixed insulin a little bit in type 1 diabetes. Just to very briefly touch on some changes to available insulins in the Novo Nordisk profile, which is actually a significant, has significant implications for us in the diabetes space in Australia. So mixed site insulin as of October 2024 is now gone, done and dusted, and you won't be able to get any new further supply of that. So if any of your patients are on this, you will need to look at alternative insulins for them. Protophane in the inlet form, so that's the pre-filled pen, will disappear as of the 25th of February, and in pen fills is only, sorry, not 25th of February, February 2025, helps if I get that in the right order, but in the pen fill version where you can put that cartridge into a pen, it's only going to be available until the end of 2026. And importantly, in the type 1 diabetes space, Levemir or insulin detamir will also be discontinued at the end of 2026 at the current point in time, and they're not replacing that, and that will have an impact on a lot of people with type 1 diabetes who use Levemir as their basal insulin. At the moment, and the Australian Diabetes Society are trying to lobby to see if we can get that maintained or get an alternative, but there is currently no plans for any alternatives. So to talk a little bit about multiple daily insulin injections. So primarily in type 1 diabetes, most of our patients who are not on a pump will be on what we call a basal bolus insulin regimen. But there are a large number of ways of giving basal bolus insulin. And every endocrinologist will have a different approach, and then every patient will have a different approach, and combine the two, and we'll get something that looks similar for most people. So everybody should have a basal insulin. That can be given as a once daily insulin using either Opdisolin or Toujeo, or a twice daily insulin, which can be Levemir. It can also be Opdisolin or Toujeo given as a twice daily form, but Levemir shouldn't be given once daily because the duration of action of Levemir isn't quite a 24-hour period, and thus you risk people's basal insulin running out if that's only given once a day. The reasons for people having Opdisolin or Toujeo twice daily are numerous. In some people, the insulin action just is not 24 hours in those people, and you will notice that they get a wear off of their insulin, their glucose levels rise if on a once daily dose, but as soon as you give them a twice daily dose, they get much better basal insulin coverage. And for some people, it's still better to split the dose of insulin, even though it works 24 hours, it doesn't quite make perfect sense, but to try and get a better profile of a day-night balance. Most people try and achieve that with Levemir rather than with Opdisolin or Toujeo because you really can get a differential effect with how much long-acting insulin they have running during the day and overnight, but you still can get a bit of a similar effect with Opdisolin. So you might notice that that's given twice daily, even though it doesn't necessarily need to be from a standard profile point of view. So everyone will be on a basal of some form once or twice a day. Then they get their bolus insulin. So that's a rapid-acting insulin, which traditionally we ask to be given, I say here with meals, but really these days before meals, and about 10 to 15 minutes before meals is the best time to be giving these insulins to get the peak effect of the insulin at the same time as the peak effect of the food that they've eaten. There are various different ways of prescribing bolus insulin. There are a lot of people who will take what I would call a fixed dose of insulin. So they will tell you that their Nova Rapid or Humalog dose is 6 units with breakfast, 8 units with lunch, and 12 units with dinner. And they take that same dose with each of those meals every single day. And that works really well for people who have a very sort of standard routine with their diet and a standard routine with their physical activity. And they know that this is the insulin dose that works for them for their meals. But you'll often find that they actually have to eat to those insulin doses. So if they want to have pasta one night, but salad the next night, they don't have that flexibility with that insulin dosing. So they will have to make sure they get enough carbohydrates in to meet that amount of insulin that they're giving. Then there's ways of people having a more variable dosing for their rapid. There's the informal dosing regimen, which I call a fudge factor, where people say, oh, I need to take something between 2 and 12 units with my meals. And well, I judge that depending on what I've been doing and how much I'm eating. And can you tell me how you judge that? No, I just do. And for a lot of people who've lived with diabetes for a really long time, it works very effectively. For other people, it doesn't work that well. But again, they might eat to their insulin, or they might have the odd low or the odd high, and that's okay. But that's what works for them to fit in within their life and what they feel best balanced or able to deal with. Then there's a much more formal calculation for the rapid acting insulin dose that you can have, where we calculate what's called an insulin sensitivity factor and an insulin to carbohydrate ratio. And they can either do calculations in their head or more commonly use an app of some description where we plug those numbers into the app, and then they tell the app how much they're going to eat in the number of grams of carbohydrates and what their glucose level is at the time of the meal. And the app will then, based on those factors that we've put in, tell them how much rapid insulin to take with that meal. Sounds really complicated. It's not really. The sensitivity factor just says how much 1 unit of insulin will adjust your glucose by. And so if they go into a meal with a high glucose level, and we obviously want to correct that down to target, then at that meal time, some extra insulin will be added to correct their glucose down to where we want it to be. And the insulin to carbohydrate ratio is exactly that. How much 1 unit of insulin will cover in terms of grams of carbohydrate. So that means that they can have their salad or their pasta or their meat and some veg or their very large pizza or whatever it is that they're having. And that dose will change based on the food that they're having, so that we cover the right amount of food and they're not eating to the insulin, but rather the insulin is working with their life.
Could I just ask, what about snacks? So afternoon tea, morning tea?
Absolutely. And so, look, there are different ways of doing this. Most people find that by the time they get to 4 or 5 injections a day of insulin on a three meals a day plus once or twice a day basal, that's enough for most people. But some people do like bolusing for snacks, and they will really notice that if they don't, their levels will go quite high after certain snacks. And so it's reasonable to bolus for a snack. The only caveat to that is that you will get stacking of insulin. So each of those bolus doses last between 3 to 4 hours. And so if you're having a snack 1.5 or 2 hours after your last meal, you will still have insulin on board from that previous dose of rapid insulin. So it's important that if someone's having a snack, they don't give the same dose of insulin they would if there was no insulin in the background. Otherwise, they'll hypo. So generally, if someone says, look, I know that when I have my coffee every afternoon and that one cookie that I always want, I'll go high if I don't give insulin for it. We just make sure they use a different dosing regimen or a different calculation so that they don't overshoot and end up going low with their glucose levels. I have some patients who insist on, giving 8 boluses a day, but it's far from ideal, and I actively discourage it because the risk of hypoglycemia is not insignificant, apart from the frequent injection factor. But yes, absolutely. For some people, they'll need that for mid-meal snacks, and for other people, actually, that dose that they've had with their breakfast will happily cover the morning tea, and will just ride them out nicely. Hang on, sorry, I've lost my mouse. Give me a second so I can advance my slide. Hopefully, no. It's always a tech problem. Any other questions while I'm trying to find my mouse? Gone completely missing in action. I have 3 screens. Here we go. Hang on, I found it. Excellent. Then there's the pre-mixed insulins, which previous to the last few years, you would only find us using pre-mixed insulins in people who just weren't able to manage within their life and the complexities of their life basal bolus insulin. It was just too complex. Having 2 different insulins got confusing. Having too many different doses got confusing. And we used to then use Novamix 30 insulin 3 times a day with meals. We don't tend to do that if we can avoid it. It causes hypoglycemia, and it really does give you suboptimal glycemic control. But the advent of Ryzodeg insulin has changed their use of pre-mixed insulin in people with type 1 diabetes, because the basal insulin and Ryzodeg, as I said earlier, is a really lovely basal insulin, and it's a real pity we don't have that available in Australia in its own right. It minimises the risk of hypoglycemia. It's really regular. It lasts a really long time. And so what we do in some patients who want that basal insulin is we'll use Ryzodeg once a day with their largest meal, or sometimes twice a day if the 30% of the rapid is too much to give with one meal to balance out the amount of long-acting we need. So once or twice a day with the Ryzodeg, and then we'll get them to bolus with their rapid-acting insulin at the meal that they're not having Ryzodeg at, so that might be 1 or 2 meals. And sometimes we even need to actually add a little bit of top-up bolus insulin with the 3rd meal, so they'll have Ryzodeg and some rapid insulin on top if they're having a really large meal. But you will much more commonly now see Ryzodeg prescribed in type 1 diabetes, and not just for those where basal bolus is too hard, but actually for those where we want that basal insulin to do the big extra in Ryzodeg. That's all I'm going to say about multiple daily injections, unless anyone has any questions about that part of things. I guess just one thing, if your patients do talk to you about their numbers for sensitivity factor and for the carbohydrate ratio, is the larger the number that comes with it, so your sensitivity factor 1 unit per 15 millimoles per litre versus 1 unit per 2 millimoles per litre. So the larger that second number, the less insulin they'll get per dose, and the same applies to the carbohydrate ratio. So if they get 1 unit per 30 grams compared to 1 unit per 2 grams, obviously the amount of insulin is quite different. So the bigger the other number, the less insulin that they get. It sometimes seems counterintuitive, but if you do feel like ever making adjustments with your patient, just remember that that goes in the opposite direction. Alrighty, otherwise I'll move on to insulin pumps. So insulin pumps, or technically known as continuous subcutaneous insulin infusions, way too much of a mouthful, come in a number of different brands from a tech point of view. The principle behind insulin pumps when they first started was the same for everyone. I'm going to talk through that first because we still use that when we start everyone off on pumps. But now all the techs have got their hybrid closed loop software, which I'll get to later, which does have an impact on the actual outcomes you get from the devices you have. So the basics of insulin pumps. It's a subcutaneous infusion of a rapid-acting insulin. So most commonly you'll see NovaRapid, but also Fiasp and Humalog will be in pumps. So just remembering though that it's only the rapid-acting insulin. These patients don't take any basal insulin with that because the infusion becomes their background insulin as well as the boluses they give, but only using rapid-acting insulin. The insulin sits in a reservoir inside the pump, and patients should refill this generally every 3 days, although Medtronic now have an extended reservoir that goes out to 7 days. It's important to remember this because that insulin, which normally we say keep at room temperature, not too hot when it comes out of the fridge, is sitting inside a little computer up against the patient's body. So you don't want it sitting there for too long, otherwise it actually does get warm and it does become ineffective. And you'll clearly notice that on people who leave it sitting in their pump for longer than three or 4 days, is that it starts to become less effective. It's infused via what we will call a set. The cannula is either a plastic or a metal cannula, so we do leave metal cannulae in patients for 3 days. And as I said, same as for the reservoir, most of the cannulas will stay in for 3 days, but the Medtronic they now have an extended set that lasts for 7 days. Patient compliance with changing these is often not great. It's just the one extra thing you have to do, and it's not a quick thing like giving a quick injection. There is actually a process involved, and it takes a little bit longer than 20 seconds. And so people will often try and extend it out for a little bit longer. There was just still a little bit of insulin left, so I didn't change it all, and it gets to 4 or 5 or sometimes 6 days, and then suddenly they'll notice that their glucose levels are high, things aren't going so well, and you can very clearly see when they should have changed and when they didn't. So this is something that often is a bit of a point that we try and remind people every time we see them, that they need to make sure they change their insulin and their set sites at the frequency that they're meant to be changing it. It's also the time when they leave the sets in for too long that you'll get kinks in the cannulae if they're not metal cannulae, or the tip of them can clog over a little bit. And so again, there's a risk of getting into ketoacidosis territory.
How common is infections from these?
Yeah, look, I have to admit, I think probably primary care would see that more than we do. They don't tend to end up in hospital, but you will often have patients come in and say, "Oh yeah, I did have a little bit of a pussy lump. It settled down, or actually I had to go and see my GP for some antibiotics." So it's, if they leave them in for too long and their skin prep isn't great and their glucose levels are high, which is another predisposition for infection, it's not uncommon to see infections. It's something I talk about a little bit later in sort of top tips for GPs for pump management, because it is something I think that we probably don't hear about from our patients as often as happens, because they don't like to tell us that they weren't changing things when they were meant to be changing things. But it's not uncommon. And certainly the kinks and not getting that insulin into them and ending up in DKA is that's a clear precipitant. Oh yeah, my reservoir was almost dry. My set had been in for 6 days and then I ended up in hospital in DKA is not uncommon.
Right.
So normally the set's connected to the pump via some plastic tubing, but there's one exception, which is that there is one tubeless pump on the market, which is the Omnipod, and I'll show some pictures of this in a minute, where everything is integrated into the one device and there is no tubing connecting at all. So pumps can be disconnected. People will disconnect them for showers. People might disconnect them for exercise. If they tend to go low with exercise, they might disconnect them if they're at the beach and just want to go for a quick swim. But you have to remember that once that pump is disconnected, there is no long-acting or basal insulin on board. So 3 to 4 hours after that pump is disconnected, they have no active insulin. And so the risk of being disconnected for extended periods of time is the risk of ketoacidosis. And so it's important to remind patients of that if they just happen to take it off and then get distracted and forget to reconnect. That doesn't happen often. I don't see that as a trigger for ketoacidosis in hospital very often, but it is just worth remembering that there's no long-acting insulin at all in these patients. The other thing about pumps is the ability for the patient to self-manage and to troubleshoot the pump is essential. If someone isn't capable of managing their own sets, of knowing when they need to change things, of knowing how to look for problems when problems arise, my glucose levels have gone high, why is that, what do I need to do to troubleshoot, then they're really not a good candidate for an insulin pump. And so while we know that pumps give fantastic glycemic control for most people and make life much easier for most people, there are some people for whom a pump is actually just too complex to manage in whatever stage of life they're at or whatever their other comorbidities are. And so there are some people who we will actively discourage from thinking about going onto a pump. It's not to say that someone who can't self-care can't be on one if there's someone who is able to care for them and learn it and assist. But it's ideal that the patient themselves can, because if that carer or support person goes away and there isn't anyone else there, then they're at risk of running into trouble. So, and I've tried to mix it up for all the different companies because I have absolutely no alliances or allegiances with any of the tech companies for pumps. But essentially, this is sort of what this is what one of the introducers or insertion for a set looks like. It's what it looks like when it goes in. So there's a little plastic cannula sitting under the skin with some tape holding it down and a connector for you then to put the tubing into. And then that tubing is attached to a device that looks essentially like an old school pager in size. This is the tubeless pump, so the Omnipod. All of the tech for this is in the pump or in what's called a PDM, and I've forgotten what the acronym stands for now, but essentially it's a disabled mobile phone which drives the pump and pairs with it and gives it the settings. But otherwise, this thing here is on for 3 days, and then the whole thing gets taken off, removed, thrown away, and the next one gets refilled with insulin and inserted. And so for some people who don't like tubing, these are a great option. And we'll see a lot more of that, I think, in the coming year, because we're about to move into hybrid closed loop with these pumps, which hasn't been available until now. So there's a big market of people who've been waiting to jump on board with these. So how do they work? And so I've talked about this as old-fashioned manual mode, but when we set up a pump new for someone, we still use these same principles and we still program these same settings and rates into the pump, because while most people now will run in hybrid closed loop, if they're not, so if the sensor is warming up or if something else happens and they get disconnected from hybrid closed loop, the pump will revert back to using the settings that are in here. So they're still important to have in and to have right. So the inherent principle behind them is that there is a basal rate, which is the continuous infusion of the rapid-acting insulin analog. The pattern is programmed to vary as the patient's basal needs will vary. So the rates can be varied hourly, although we don't like hourly. If you have 24 different basal rates, then someone set it up wrong, because they shouldn't need that. But it's fairly common to have 3 or 4 different blocks of basal rates in the old days settings per day for people. In particular, that dawn phenomenon is really well addressed by having a different sort of basal rate set up for before people wake up. But there's a whole lot of other things in there as well that we use it for. These basal rates can always be temporarily altered for sick day management, for exercise, and those sorts of things. Then there's the bolus for carbohydrates. So this is where you're having a meal or you're having a snack and you will bolus for that. And we program into the pump the insulin to carbohydrate ratio, so 1 unit per X grams of carbohydrates. They can bolus for all meals and snacks because the pump adjusts in its calculation how much insulin is still on board from the last bolus, and they'll subtract that appropriately from the next bolus. So with a pump, they don't need to inject differently because they've got the one set that's sitting there, and the pump will already do that calculation for them safely so that they're not going to have that same stacking effect with insulin. Then they can also bolus for hyperglycemia, and they can do that separate from a meal, although usually this all gets built in with the one meal bolus, and people don't tend to bolus more than for their food. But that's where you've got your sensitivity factor, or some people might refer to it as a correction factor, and that means that 1 unit adjusts your glucose level by Y millimoles per litre. You can also set up multiple profiles in the pump, really useful for people who do shift work, for those who know that exercise has a significant impact on their glycemic control, and for women around the menstrual cycle as well. It's really quite helpful to have a different profile, potentially if they have extreme variability in their glucose levels around that time of month. Now, the above settings that we've just talked about are variably used by the different hybrid closed loop software. And I'm not going to go into the details on them all because each of the different tech companies has something different. But essentially, these still remain the fallback rates and the fallback principles behind how a pump works. The different brands or terminology that you will come across, I think, is helpful, because when someone comes in and says, oh yeah, I'm in SmartGuard and blah, 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 you go, well, hang on, what's SmartGuard? So Medtronic, the current model is the 780G, and most people will be on that, but that model will change with time because they always do, has its hybrid closed loop that links with it, which is called SmartGuard. AMSL is the T-Slim pump, and its hybrid closed loop software is called Control IQ. I'm pretty sure I've got this right for Ipsomed because it's a bit of a mouthful, but they have the MyLife Ipso pump and the MyLife Loop, and that runs through the phone. Kristine's nodding, which means I've got it right. The Omnipod, we currently only have the Dash, which doesn't have a hybrid closed loop system. So this is the one that doesn't have tubing. But we've just recently had TGA approval in Australia for the Omnipod 5, which will have an automated insulin delivery system. And I couldn't see on their website what that's called. So whether it will have a fancy name or whether it will just be called the Omnipod 5 with automated insulin delivery system is yet to be clarified. But that will be a bit of a game changer for them because they've been behind that hybrid closed loop issue for a while, and the hybrid closed loop is very appealing to people.
Could I just interrupt, Carolyn? So a hybrid closed loop is integrating the pump into the CGM. Is that correct?
So I'll come to that. I've got a little section on that to follow shortly. I've kept it separate because not everybody uses it, although really they sort of do now. And that's been the big thing. I mean, the data suggests, just to give, I guess, a bit of context behind it all, that people living with diabetes make about 190 extra decisions a day. I don't know how many decisions hybrid closed loop software removes, but it's a very large proportion because it makes a lot of adjustments for them. It doesn't completely rule out them needing to still actively manage their type 1 diabetes. There's still a lot of decisions that need input to make the pumps run well, but you can step back and do an awful lot less and still have better glycemic control than you did previously. So I'll talk a little bit more about the different hybrid closed loop shortly. So I think these were my top tips for pump management and primary care, because essentially what we don't expect primary care clinicians to do is to adjust pump settings and to manage these pumps. This is in the realm of the endocrinologist. It's what we expect to do. It's definitely in the realm of our diabetes educator colleagues as well, and it's what they also do very well. But there's things that patients will see you about, or things that you might want to check in on when they see you if they're running an insulin pump, which I think are really helpful to have either someone else also checking in on, as well as the endocrinology team, because they may not link in with their diabetes service very often these days. And also things that they're more likely to present to you with acutely than perhaps they would with us. So insulin prescriptions is one of them. So they will all use only a rapid-acting insulin in the pump. And when giving them the script, it's important to check whether they use the pen fill, which is the little cartridge, which most people will use to fill their reservoir. Some people still, for reasons that are less clear to me, like to use a disposable pen and wind it up and click it in and wind it up and click it in to fill their reservoir. So just make sure you check with them about which of those they would like on their prescription. While I don't think that the disposable pen is the best way to do it, if it works for someone and it's their routine, I personally don't change that. I leave that to the diabetes educators when they see them. But people may have a reason for why they do what they do, and if it works, I try to stay out of that a little bit. Pump failure, I think, is important because you may see it earlier than us, and we may be able to stop people needing to come into hospital if their pump fails. So I guess red flags for an acute episode of pump failure are hyperglycemia that is not correcting to them having bolus through their pump, or in the hybrid closed loop software to the pump trying to correct itself. And in particular, the development of ketones means that their pump is not doing what it's meant to be doing. A really safe and easy and effective way of making sure you get them out of acute trouble is to inject some rapid-acting insulin via a pen. So the pump can still be in, but to get a pen and to give them some rapid insulin, which will address the ketones and address the hyperglycemia. That means that you know that you've got the insulin into them, separate from any of the pump issues. They should change their set, line, and reservoir. And that doesn't mean they change one and not the other, because it may be that their reservoir was empty, or the insulin in the reservoir has been there for 6 or 7 days, and changing the set and line won't fix it. Or if they change the insulin in the reservoir because it's been there for 6 days, but there's a kink in that cannula, that won't fix it either. So they should change all three. And then if it's an actual tech issue with the actual physical pump itself, then they should be contacting the pump company for a replacement. And the pump companies are meant to replace within Australia. Correct me if I'm wrong, Kristine, it's still 24 hours that they're meant to.
Yeah.
They don't always. So they need to have an interim management plan, but they should be able to get that fairly quickly. The thing patients need to realise is when they go overseas, even though these are all global companies, it's still the Australian version of the company that will support them even overseas. So the replacement is a significantly longer lag time if they're away from home. So the interim management for people, if their actual pump has died and changing the line to set the reservoir hasn't fixed things, is that they will then need to bolus with meals in the old-fashioned pen and needle way, and they should also then be using basal insulin once or twice a day. And I normally will get them to split their basal insulin into twice a day, because that way, as soon as the pump comes, they've got a much quicker put the pump back on period than having to wait until they would due that next dose of basal insulin. But some people prefer not to do twice a day and are happy to wait that little bit longer. People should all know their pump failure dose. I say they should, but they don't. It'll be written down somewhere in a drawer somewhere, and they've forgotten where they've put it, is the most common thing, because it always fails at the least expected time and a long time since they were first educated about their pump, is my general experience. So oftentimes they will call us, and that's okay if they need to. We do have someone on call 24/7 if we need to at the hospital to deal with these things. I prefer it not to happen at 2 in the morning, because it's very hard for me to troubleshoot for someone at 2 in the morning. But if they've ever uploaded their pump, and we do encourage them to upload their pumps for their appointments, they can go back and look at how much basal insulin was in that, they were using on their pump settings from their last upload. And from that, they can then work out what their dose is if they've forgotten how much. Essentially, when someone's pump fails, we don't try and get good control. All we want to do is keep them out of trouble, keep them out of hospital, and keep them out of ketoacidosis until they get their replacement pump and can get everything loaded back into it. But if they don't know what their pump settings were, they also can't start their new pump when it arrives. They need to know what those settings are. So actually making sure that, occasionally checking in with the patient and making sure that they know what their pump settings are, where they put the printout, or how often they're uploading, so that they can come back to that data if they need to, is really helpful. Kristine, is there anything you wanted to add to that?
Oh no, not really, except that we do teach them that, you know, to have a bit of an idea of how much insulin they're putting in their reservoir, so they know what their total daily dose is. So at worst case, they can halve that. That becomes their basal, and then they can split that again, like you said. So yeah.
And so a lot of people won't keep basal in the fridge at home because they'll find it goes off before they've ever needed to use it. But so long as they've always got a script with them wherever they go, they can, you know, survive with Nova Rapid every 3 hours overnight and start their basal up the next morning when they get to a chemist. Traveling with pumps, often people won't time their appointments for travel particularly well, and so they might see their primary care team instead. So making sure that they always travel with a travel letter is really important. That needs to say that they're going to be taking insulin, which is a liquid, that they are going to be having needles with them, and that they are safe, that they're medically safe to travel. Ideally, these days, we also want to make sure that there is some acknowledgement that the patient doesn't go through the body scanner at the airport. They have to go through the old school metal detectors, but not the body scanner. And any of the supplies that relate to their sensors don't go through the X-ray machine, but get taken out and passed over and across, and the security guards can just do a visual inspection of those devices. They should really carry everything with them in hand luggage. I don't like people checking in anything to do with management of their diabetes, and I tell them that very clearly. Their hand luggage will be mostly their diabetes supply, and you know, the rest of it, unfortunately, just has to be smaller compartments in their backpack as required. They also need to make sure they do take their pump failure supplies with them, because you can guarantee if your pump's going to die, it's going to be when you're overseas, and you don't want to be doing 3-hourly rapid-acting insulin injections for another week while you're away because you didn't take your basal insulin in insulin form with you. This was the touch on site infections. So getting back to what you asked about earlier, Leonie. So obviously, if there's any hint of a site infection and they've still got the cannula in, remove the cannula. Some of them may look, you know, pretty minor, look like they'll heal once the actual cannula has been removed, but oftentimes people will need antibiotics for them. Appropriate skin antibiotics is all you need. Very occasionally people will get a deeper abscess, but that's really, really unusual. Normally it's a fairly sort of minor, superficial sort of skin infection with perhaps a small collection. If they come and see you with a site infection, it's really good to check about skin prep and make sure they're actually cleaning their skin properly before they're putting in their sets, and how long they're leaving those sets in. And if they get one infection, fine, these things happen to everybody. But if they happen more than once, then please refer them back into their diabetes educator, because it may be that that particular set is not a good choice for them. And that's often where we'll encourage, in particular, the metal sets for people, which are less likely to cause them problems. But also maybe the technique actually just needs a little bit of a revision, and seeing their educator is a very helpful way of making sure they remember how to do things properly. And then the only other thing to check in, because people do drop out of the system and we're very aware of that, is that their pumps are only in warranty for 4 years. And as a service, we need advance notice for an upgrade, because we need to make sure that we're comfortable that their carbohydrate counting is good, that we've done all the paperwork, we've dealt with their insurance company, and all of those other things have happened, and then that we have time to book them in. And so If they haven't seen an endocrinologist or a diabetes educator for more than 3 years and they're on a pump, it's probably worth making sure that we get an early referral so that they don't log in with you haven't seen me for 4 years, but I need my pump and I needed it yesterday. It doesn't tend to work very effectively for them or for us. Any questions before I move on to continuous monitoring? I will keep cruising because I'm probably going over time. So continuous glucose monitoring, just I guess a few key points. One is that it measures interstitial glucose. So the absolute value will differ a little bit from capillary or blood glucose. There's about a 15-minute lag for that glucose level being read in the interstitial fluid. So it's not exactly the same number, even if it's done with a time lag, but there's also a time lag for these numbers being read by the continuous monitors. There's the 3 systems available in Australia, the Libre, which started as a flash system and is now changed to an integrated sensor and transmitter. Sorry, that's a typo. And they get worn for 14 days. These are the things up the top. They're about the size of 2 20-cent coins stacked on each other. They're really easy to apply. They are very easy to use. They don't need much dexterity to get in, harder to take out, I think, than put in. And then there's the Dexcom and the Medtronic with their various different models, and I haven't put all of them up, but the ones that you'll most commonly see. They have a reusable transmitter, so you actually separate it, and that's why I put this photo of the Dexcom like that, so you can see that they're actually 2 separate parts, and they are worn for slightly different durations of time. But essentially all of them do a similar thing. They will give you your current value, your glucose in millimoles per litre. They will tell you of trends, and you can set alarms for lows and for highs. High alarms, I think, are a variable utility depending on the person, but can be quite annoying. But low alarms for me are non-negotiable because they're the ones that will save your life. And so I'm very strict about my patients having low alarms set, but I often will tell them to turn off the high alarms because they tend to drive people a little bit crazy. The other thing about all of these devices is that glucose levels can be shared with someone else in real time. I'm not a pediatrician by any stretch of the imagination, but adults also like to have someone else know what their glucose levels are, and it's a really easy way of someone else knowing that they're being kept safe and that you can check in if you're worried about what their levels are looking like. I have stolen this from the Libre website just because I can't do graphics as nicely as they have, but it's a really good pictorial to explain that while the levels are accurate, there are always going to be differences. So if you look at the yellow box being what a continuous glucose monitor measuring interstitial glucose does, and the orange being your blood or capillary glucose levels, when things are level, they will match, give or take a little bit. And it can be it's generally thought to be about up to 0.3 millimoles per litre variability, but it's not always exactly that. It can vary a bit more than that. But when the levels are rapidly rising, you will have a significant lag in the interstitial glucose because there's that time for it to shift, and same as when they're rapidly falling. And it's probably most important when they're falling. So if a patient feels hypo symptoms, but their continuous sensor does not tell them they're having a hypo, that's when we still tell people to actually go back to old school finger pricks because they'll know what their actual blood glucose level is at that time point, or trust the symptoms and treat a low, but preferably if they can to check. So never to ignore hypo symptoms if your sensor doesn't tell you that it matches how you're feeling. I think it's really probably the most important thing that people often forget is, oh no, my sensor said I was fine, so I ignored it. Actually, your levels were low, but your sensor hadn't caught up yet. The data generated from CGM, which is visible in various forms in the different apps that are all associated with the different brands, but that you'll see us talk about a lot in our communication now about patients, and we focus on that more, I think, than looking at the absolute numbers necessarily, but is time in range. I'm slightly harsher with my target. I make it 75%. I think technically the guidelines say 70%. Lows, you want less than 4%. And there's the highs and the very highs. And I personally ignore the highs because I'm not really that worried about them. They're marginally elevated and I don't focus on that too much. But the very highs, the lows, and the time in range is really where you want to be looking. We also get what's called a GMI, which is the approximated HbA1c. So if someone hasn't got blood tests done, but they've got some sensor data, or if they've had a significant change in glycemic control recently, that GMI will give you their estimated A1C based on generally the last couple of weeks of sensor data. So it's an accurate at that time point as to what you expect their HbA1c would be. And then we also look at the coefficient of variation, or the CV, which is an indicator of glucose variability. And our target for that is less than 36%, to be quite specific. But that just basically tells us that no longer do we just look at the A1C, because the A1C is that smush of all the highs and the lows and the everything else is put in together. And you have people who used to vary or still do vary between a glucose of 2 and 20 all the day, and they go up and down, and their A1C might look beautiful, but actually their glycemic control is horrible, and that really big variability is actually worse for you than sitting marginally elevated for a sort of a steady period of time. So the coefficient of variation is a really useful indicator for us about glycemic control, and something that we'll look at. You can then look at daily graphs and all sorts of other fancy schmancy graphs, but they're of less importance. The daily graph, though, is very helpful to look at where those trends are. So just to show you visibly what it looks like, and again, I've taken this from one of the apps. They all have something that looks reasonably similar, but perhaps a different color coding. But essentially your time below range, your time in range, your time above range, and your very high. And so this is from one of my patients that I stole from the last couple of weeks. Time in range isn't great, but as you'll see, he doesn't have very many very highs or very many lows, which actually means that overall things are pretty good. And his estimated A1C based on that data was 7.4%. Coefficient of variation pretty good at 25. And so, you know, while his time in range might not be perfect, actually that's not bad glycemic control. There's definitely things we can do to get it better, but this is actually not too bad at all. This is someone else's trace that I stole, and again, you know, they all look slightly different but similar, is that you will get a line that tells you what happens over a full 24-hour period, with a range that is preset that tells you ideally where you want to be. So you'll see the trends to down. You can tell when they eat. You can tell when they've had something to treat an impending hypoglycemic episode. You can tell at other times when they've eaten and when they're out of range and in range. And then just very briefly to talk about the hybrid closed loop pumps in a little bit more detail. So this is where the CGM or sensor feeds information to the insulin pump, which adjusts the insulin delivery. So each brand has its own software. It all works slightly differently. Some of them are predictive and some of them are reactive. But essentially, the adjustments to insulin delivery that are made because of this hybrid closed loop includes auto suspends prior to hypoglycemia, so it should stop people going low by the pumps choosing to suspend when it can predict that you'll go low, adjustments to basal rates, and automated boluses for high glucose levels in some but not all of the hybrid closed loop models. The person living with diabetes should still ideally bolus for carbohydrates. They will still need to adjust for exercise, and that adjustment type will depend on the pump. And these systems are not great for intercurrent illness or glucocorticoids. And the reason they're not is that the pump and its algorithm doesn't understand the why. So it looks at your numbers, it can look at the data, but it doesn't understand why those levels have gone high because you've just had a 50 milligrams of prednisolone, or that you're sick with a urinary tract infection. And it doesn't understand that you've exercised if you don't tell it you've exercised, and that's why you're going low. So the algorithms are excellent at standard day-to-day glycemic control, but when there's something that's out of standard for an unusual reason, they don't tend to work as well. But again, if overall things work pretty well, we accept those, and then we just ask people to manually adjust as needed. And so when someone's on hybrid closed loop, you will see there, you can look at data that shows you what their actual glucose trace is. You can look at when the pump is giving a bolus, when the patient is giving a bolus for their carbohydrates. You can look here in the pink at where the pump suspends, and you can look at where there's changes to their basal rates, and other things that the patient may have done to adjust things. So there's a whole lot of extra data that comes into how we interpret that. Definitely out of the realm of something that we expect you to have time or that sits in the remit of primary care, because it's getting more and more complex, and our job now is not to necessarily adjust the insulin doses based on what we think should happen, but how to cheat the software so that it does what we want it to do, because we understand the why that it doesn't. And then one last slide on treatment targets, because I've gone over my time, unless there's any other questions. Really, my most important message here is to individualize. You know, an HbA1c target should not be the same for every patient living with type 1 diabetes. Generally, as a rule these days, we can get between 6.5 to 7.2 is kind of where you want to sit, but it is highly variable. That time in range of greater than or equal to 75% to me is probably a much better indicator now than the HbA1c itself. And I mean, I guess if we think about the fact that we've got subsidized continuous monitors for everyone living with type 2 diabetes, the reason for that is that we know that having that data improves glycemic control without us doing anything else as the treating clinicians, because people are responding to those glucose levels, and that time in range is a real indicator of that. We want low rates of hypoglycemia, and I will sacrifice time in range to eliminate hypoglycemia, because that's a much more significant and more acute complication and risk. Obviously, looking at that coefficient of variation as well, trying to get rid of the Swiss Alp traces, but rather having people much more level with their glycemic control. and trying to minimize the risk of end organ complications. And so it's a matter of putting all of that together while also making sure that the person living with diabetes has good quality of life, and that we're not causing diabetes burnout by focusing too much on all the nitty-gritty and finicky things, to then get to where our treatment targets should be. And that, in a very quick nutshell, was the end of my A to Z of insulin. I'm open to any questions. Otherwise, we can.
That was great, Carolyn. Thank you very much, and it was very comprehensive. Can I just ask you a small question? So, in people who play in contact sports, how often does the CGM get ripped off?
Not very often. Kristine's probably going to answer that as well. So there are extra, I did have that actually on one of the photos to prompt me, but there are extra tapes and things that you can put over it, and people will often get sort of elastic bands or tubey grips sometimes, depending on what they do and what they think their risks are. But really, actually, they're not as easy to rip off as you think. It does happen, but not that commonly.
Right.
It can also come down to placement too, Leonie. Like if someone's, playing rugby, you probably wouldn't get them to put it on their arm. You might ask them to put them on the bottom or something. So, and different type, you might suggest a different type for someone, but based on what exercise they're doing.
Yep. Okay. Thank you. Thank you so much, Carolyn. So do you want to stop sharing your screen?
I'll do that.
And we just had a few gremlins today, so I'm going to be the screen monitor for Kristine. So just bear with us. I'm sorry about this. Here we go. And here we go. Okay. There we go. Have you got that up now?
Yeah, I can see that.
Great. Okay. So off we go. Thanks, Kristine.
Okay, no worries. So yes, I can manage diabetes okay, but obviously not IT when it comes to doing things from home. So I'm just going to talk about when I was organising my presentation together, everything came down to have a plan. So I've kind of entitled it Having a Plan. So we could just move to the next slide. We've already done the acknowledgement of country, so I might skip through that one. Okay, so my objectives, obviously all of it's about type 1, but I thought I'd cover sick days because really we need our people to have a sick day plan, have a plan around how to manage alcohol and parties, have a plan around how to manage their exercise, and just, I'm sure you all know about driving, but we'll just touch on driving briefly at the end. So we can go to the next one. Thank you. So if you look at the 6 days here, it's all about the plan. I've got the 2 different plans up. So one is one on an insulin pump, and then the other one is on injections. So we use the ADA resource here. It's quite a good resource, and it's got a nice flow chart which helps. So we can just go to the next slide. So sick days, to manage sick days. So again, this is probably a revision for you, but it is regular glucose monitoring. Need to make sure that person's having a good assessment of where things are travelling. Ketone testing, if their glucose levels are above 15, or if they're vomiting. I say to our clients, I don't actually care what your glucose level is if you're vomiting. We need you to detect ketones at that point. Eat and drink normally if possible. Seek medical advice for any underlying cause of the illness. And diabetes doesn't necessarily cause illness, but it does not manage well, and as a result, and can result in an illness such as DKA. And of course, we advise to give supplementary insulin, rapid-acting insulin as per our sick day plan. And then when to get urgent medical help, if glucose levels remain elevated despite correction insulin, and we usually say around if we give supplementary or correction insulin twice, then we need to get probably some help around what to do next. Ketones, we tend to say above 1, and if you're vomiting for more than 4 hours, that just means that you're in a world of pain, and it's always really, vomiting is quite tricky to manage, and we often need the endocrinologist to help us there. And if experiencing abdominal pain, of course, that's the beginnings of DKA. Well, probably on your way. If we can go to the next one. So this is an example of the flow chart. So this one's the one for the multi-daily injection. So you can see up there, it's quite clear. So you've got your, if you're feeling unwell, glucose level above 15, then please check ketones. Now, if you don't have ketones, then keep monitoring and then, take your insulin as you would normally, or potentially even give a correction dose. Because, I mean, you might have a lovely meal out and have a glucose level above 15, but that doesn't mean you're sick. That means you probably just need a little bit extra insulin to deal with that meal. However, if you do have ketones present, then you'll see down on the chart that you've got a couple of options. So if you've got ketones between 1 and 1.5, then we want you to give 5 to 10% of your total daily dose of insulin as a correction dose or a supplementary insulin dose. Or if you're that higher end of things and you're above 1.5, then we want you to give 10 to 20. And here I always say to people, if they're not sure, you can always put more insulin in. You can't take it out. So don't necessarily jump to your highest number, potentially. But also in saying that, we know how resistant people are when they're unwell because of the stress hormones. So really, insulin just doesn't go as far as it normally does. But it's a good guide. It's a solid guide. And often when they're with us, I go through and go through their total daily dose of insulin with them, add it all up, and then have an idea of what 10, 15% and get them to practice. But that doesn't mean they're going to be sick the week after I give that advice. It could be a year or so later and they've probably forgotten. But we do tend to write on the side what a total daily dose is because that's the key to it all. If we can just go to the next one. So this is the pump version. It is pretty similar, really. It is just basically saying that, as Carolyn's already said, insulin pumps do really well on a day-to-day basis, but if you're requiring more insulin because of sick days, they don't often play the game all that well. And yes, you can go back into what we call manual mode and run extra insulin through basal profile, like you can give an extra basal insulin, temporary basal adjustment, but it doesn't always work as well. And sometimes you might just need to give an actual injection using a pen, particularly if your sick day is a result because the pump has failed as well. So sick days can cover not just being unwell, but also pump failure. We might go to the next one. Okay. Alcohols and parties. So I get to talk about this a fair bit. I work in the young adult clinic on a Tuesday afternoon. So this is one of the ones we kind of go, we talk about the sex, the alcohol and the drugs. So we tend to do all three, but we'll just stick to alcohol today. So we can just go to the next slide. Okay, so the risk of excessive alcohol use is going to be hypoglycemia. So you don't need to tell me, but don't need me to tell you the impacts. But when liver's processing alcohol, it cannot protect against hypoglycemia as well as if there was no alcohol present. So alcohol, obviously the liver can really only do one job at a time, and it will choose to always process the alcohol. Lasting effects of alcohol too can have a delayed glucose lowering effect for up to 14 hours. So when we talk about having a plan around partying, it's not because we want to have excellent glucose control for that period. It's about being safe. So we can go to the next slide. Okay, so having a plan, and this is quite a detailed plan, and I got this off the, which is pretty much what we talk about all the time, but the Royal Children's Hospital from down in Melbourne, and they have this on their website, so it's quite easy to have access to. So having a plan before going out. So eat normally. So, some people go, oh, I'm going out tonight, or, I want to, look good in my latest outfit, whatever, and don't eat for the day. We encourage they do eat normally because obviously we know if they don't eat, the alcohol is going to uptake more quickly than if they had eaten. Check glucose levels before going out, and having a support person that knows that you have diabetes and can support you through the evening. What to take to the party? Well, most of our people with type 1 diabetes do wear some kind of CGM, so hopefully they're wearing some monitoring, some identification, because I think we've all heard the horrible stories about somebody who's having a hypo mistakenly thought of as just being drunk and not being treated appropriately. So having some ID is always a bit of a good idea. Carrying snacks. Young people particularly, they don't have a lot of money. So, eating out is not necessarily an option. So carrying something with them if they need it is a good idea. And, of course, always carry hypo treatment, your rapid-acting glucose, whatever that might look like. And then at the party, where possible, eat regularly throughout the evening. And if not eating, consider using a full mixer with you. So if you're having your lemonade and your vodka, so have full strength lemonade, particularly if that party, because we know there's parties and there's parties. There could be parties where you're sitting around and chatting, or there's parties whereby you're on the dance floor, and that's exercise. So you certainly need to have that carbohydrate, or in a liquid form, or a food form, depending on what they're prepared to do. Never bolus for alcohol, because we certainly don't want to increase the risk of hypoglycemia, and keeping an eye on glucose levels. And then the big one is, what do we do when we head home? Okay, so check glucose levels before bed and eat before bed. We go call past Macca's on your way home. Grab that, cheeseburger, the fries, whatever it is, because it's nice and carby and it's greasy. So it usually will hang around and keep you safe when that when that alcohol is starting to dissipate, and that it's coming, your glucose levels are coming down. So it keeps you nice and safe from, hopefully, from having a hypoglycemic event. And when you get home at 3 a.m. in the morning, you can't really wait, sleep all the way through to 3 p.m. the next day. You really need to be thinking about waking up at a close to normal time, so you can check what your glucose levels are doing. And having a support person, maybe that may be mum if you're a teenager, or whatever, or that might be someone you live with if you're a little bit older, just so they know that you're still alive and breathing. All right, so exercise, again, having a plan. And I'm probably going to talk more about planned exercise than unplanned. If it's unplanned exercise, then really our best friend is just to eat. But we might just go to the next slide here. So when to exercise. So I suppose someone with type 1 diabetes, as Carolyn's already alluded to, there's so many decisions that get to be made in a day. So, and that's just, normal routine. So you throw in exercise, particularly if a person's very keen about their exercise and it's very important to them, then it means there's a whole lot more decision making to be made around it. So your glucose levels before you even start the physical exercise. So you need to have an idea of what's going on, what your trend is. Are you trending down? Are you trending up? What's the deal here? The amount of time you had some insulin, particularly short-acting insulin. What was eaten for that meal or snack before the activity? Did you have a lower GI carb, or did you have a higher GI carb? Was it fatty? Was it not? There's all of those things to maybe take into consideration as well. Your fitness level. If you're fitter for an exercise, your glucose levels are probably less likely to react significantly than if you're not fit for that particular exercise. The intensity and the duration of the activity to be performed. So the longer the duration, you're obviously going to have to replace the carbohydrate that you're using throughout that exercise. If we can go to the next slide. Okay. So I suppose now talking about hypoglycemia and hyperglycemia before exercise. So if we all just address hyperglycemia first, okay, so if we've got a higher glucose level before exercise, I think we need to know why we've got that higher glucose level. I don't think there's a blanket don't exercise. We tend to say that with our newly diagnosed people because we haven't taught them about it yet, but most people who've had diabetes for a while will say to you, oh yeah, I know how to get my glucose levels down. I just do, go for a walk or whatever. And that's in most cases safe as long as there's no ketones present. So if you've got a higher glucose level, but you've had some insulin in the recent past, then exercise is probably fine. If you haven't and you don't feel particularly well, and you basically need to check ketones. Okay, so if there's no ketones present, it's fine. You can potentially give a correction dose of insulin, and you would always reduce the correction dose that you might usually give because exercise is going to make you more sensitive to the insulin available. And then you can go and do your exercise. Now, if you have ketones that are less than 0.6, again, you can give that adjusted correction dose, and you might do that low to moderate intensity exercise. So that might look like a walk or something, but you wouldn't potentially go and, go hardcore and do a huge heavy intensity gym exercise or whatever. You might be more gentle that day. Again, if you have ketones between 0.6 and 1.4, again, you can give a correction, and you would probably just do your low intensity exercise, a gentle walk for less than 30 minutes, because we don't want to make things worse. And of course, if you have ketones above 1.5, then you just need to give a normal correction, and you need to wait, and exercise is off the table for that particular day or that time. Okay, so exercise type. So there's different types of exercise, obviously. So you've got your more flexibility, stretching exercise, and then you've got your aerobic, your anaerobic, and then your mixed. So you can see by the dotted lines beside it that that's kind of the direction of the glucose level. So if you're doing that more weight-bearing intensity kind of exercise, it tends to hold the glucose levels fairly level. Aerobic exercise tends to drop during the exercise. Anaerobic tends to push the glucose levels up initially and then down later. And then that mixed, so like maybe a soccer game or a hockey game where you've got that high intensity for short periods, but then you've got the cardio component, can have more of a balancing out effect as you go through the sport. Okay, if we go to the next one. So after exercise, this is probably quite key. So monitoring glucose levels post-exercise is obviously quite important, in the sense that we want to make sure that somebody's not going to go experience hypo or stay low for long periods of time. We always ask people to consider reducing their basal and bolus insulin post-exercise. So if using MDI, this could be up to 70% of their bolus insulin they need to reduce it by, and if it's their basal, maybe 20 to 30, reduce it by 20 to 30%. So when we say reducing the bolus insulin, that's if that meal is in with 2 hours of that exercise. So if you've exercised within the 2 hours prior to the meal, or you're going to exercise 2 hours after the meal, then you would consider reducing the bolus. If it's outside that period, you probably don't have to reduce it all that much. And the basal insulin, particularly if you're going to exercise in the afternoon, you would really consider reducing it. Or if it's a prolonged exercise that's gone on all day, so they've been bushwalking or trekking or had a sports day where they've been active all day, then you would consider reducing that insulin for the evening. If using an insulin pump, you can consider using the exercise profile if available, or which is all the pumps tend to have a version of this. So it basically means that the target that the pump is working to normally to give insulin and keep in target range is actually elevated, so it's a higher target. It could be 8.3, it could be 8.7. It depends on the pump that you're using, but it reduces the amount of insulin in delivery so that you don't overshoot the mark and go into a hypo episode. You've got an increased risk of hypoglycemia for up to at least 12 hours post-exercise. And consider eating 20 to 30 grams of protein with carbohydrate post-meal exercise for muscle recovery, of course, but also for stability of glucose levels. So that protein is going to be digested more slowly and it holds the glucose level more stable. Okay, driving. So just this is, again, probably just a little bit of revision for you. So if you just go to the next one for me. Okay, so we need to be above 5 to drive. We're checking our glucose levels before driving. We're checking every 2 hours to ensure that whilst driving, so we're ensuring that they're above 5, and we're always carrying our hypo treatment, of course, with us. I whizzed through that a bit quicker. It was a bit slow when I was practicing. Is there any questions at all?
Sorry, I'll have to stop sharing the screen and then go on to look for the questions this way. It doesn't look like there are any questions, but that's very interesting. And so with the driving and type 1 diabetes, are you aware how often do they, with the driver's medical, can you do it, you know how there's some kind of, with the New South Wales driving, you can choose a review period, but does it have to be annual?
Well, that's really less. That's actually on the endocrinologist a little bit, I suppose. They can choose 1 to 2 years. It's entirely up to them.
Yeah, and so I mean, I'll jump in there. We normally, unless there's a very good reason not to, we will normally stick with the standard interval of a conditional for 12 months. It's just a really good reason to have that safety net and check. A lot can change in a year, and if you leave it for 2 years, an awful lot can change. And so I think it's a good reason for us to make sure that we have that conversation, in particular to revise the drive above 5 rules, which are so important. And it's every ignition turn or every 2 hours on a long car trip. It's not, oh, I checked it once this morning, it's been a few hours and I'm going to drive again, but that's okay, it was fine this morning. It's every ignition turn.
Yeah.
And to make sure that there's no end organ complications that have developed that again will impact on their ability to drive as well. So as a rule, I don't know many people who will choose to extend that period of time unless we know very confidently that there is zero risk, just because it's not that hard a form to fill in. It's a nuisance, we understand that, but it is a safety measure for the patient and the community. And so most of us don't want to take that risk of something going wrong that we could have prevented. We can choose to make that, whether that's GP or whether it's treating specialists, obviously, except for the heavy vehicle licenses. But, as a rule, I think it's a really good reason to check in and to make sure that there haven't been any hypos that we're not aware of. The other thing that often gets missed, is the severe hypo. So a severe hypo, by definition, is any hypoglycemic event that needed external assistance to manage. So that's not, I called an ambulance necessarily, but that certainly counts. But it can be, I was hypo at home and I really wasn't aware. My partner had to say to me, hey, you were having a low, here's some food and have that. Because if they get to that neuroglycopenic stage without having any of those earlier warning symptoms, that's where the risk is involved. And a severe hypo means that you should not be driving for 6 weeks by the fitness to drive rules, and you have to be cleared to drive without, with a review to make sure there's no ongoing hypoglycemia and that's been minimized. And it's not uncommon that I'll see people come to appointments and they'll tell me, yeah, the ambulance was called and they got glucagon 4 or 5 months ago, not long after they saw me potentially. And I haven't then seen them for a number of months, but I didn't hear about that and they kept driving and weren't aware. So it's a good reminder as well, just to remember that a severe hypo is any external assistance needing to treat that hypoglycemic episode, and that precludes you from driving for 6 weeks, and you have to be reviewed before you can restart.
And when you say reviewed, it's reviewed with the specialist, because there's different types of reviews on the form.
Yeah, absolutely. I mean, unless there is for some very strange reason an inability to see a specialist, absolutely it should be with the specialist.
Yep.
And we will always make appointments for people who've had a severe hypo. That's an urgent review by us and by the educators, and we keep a really close watch on them until we've got back out of hypo zone.
Yeah. And sorry, probably many of the attendees know this question, but I don't, so I'm going to ask it. With the pumps, what's the kind of funding for them? Is it mostly people are getting them on their adults getting them on their private health insurance?
I'll let you answer that one.
Oh. Yes, it is. For those under the age of 21, and depending on what their income, their family income looks like, they can be eligible for a pump through JDRF. But after the age of 21, then yes, it is. It's private health fund. And like all of the pumps are roughly around $8,500. So most, as long as you really need to check with the health fund, because they've gone to that gold, silver and bronze and all the rest of it. And it used to be just basic hospital cover would cover an insulin pump, but it's now really you need to check, because some people have been caught out and thought that they had basic cover and it precludes insulin pumps. So,
Right.
yeah.
But and they always need that 12 months of having the insurance first. So, I mean, there are ways that we can arrange loan pumps for people who've taken out insurance and don't necessarily want to wait the full 12-month period, but they do need to make sure they've had pre-existing. The sensors, however, are subsidized for all people living with type 1 diabetes now. So they're free for anyone under the age of 21, anyone who is planning a pregnancy, pregnant, or in the immediate post-natal period, and anyone on a concession card. Or any Aboriginal and Torres Strait Islander people. I don't think I've missed any of those categories. For everybody else, it's subsidised down to $32.50 a month. So essentially $1 a day will get you your CGM subsidised for those who don't meet the other concessional status or high-risk categories. But it is only type 1 diabetes. It's not your pancreatogenic diabetes. It's not your cystic fibrosis-related diabetes once you get over the age of 21. And so it's important, again, just to be aware that those groups don't automatically fall into the subsidy categories. We can sometimes get exemptions, but that's the exception and not the rule.
Right. And how much are the pumps reliant on the mobile phone network to be up? Like if you're in a remote area or where the mobile phone network, so it's not relying on that, it's more Bluetooth?
Yeah, look, it's only the only one that's relying on a mobile phone is actually the Ipsomed pump, because the app on the phone directs the pump. Even that, if the phone is down, you can still use it in manual mode, but not in the hybrid closed loop. But the other ones are all can talk directly from CGM to pump, and they don't. Like, some will have the phone, because then you can just pull the phone out and see where you're up to, and you don't have to pull your pump out. But they aren't reliant on the phone. So it's really only Ipsomed. The rest of them, yes, they'll function quite well without internet, because they're Bluetooth.
Yeah, and if your phone's died, they'll still function. You could just look at the pump.
Yep, absolutely.
Yep.
Yeah.
Well, if now is your chance, attendees, to type in some questions, because we've got two very wise and experienced diabetes experts with us tonight. So I'll just wait for a couple of minutes and see if anyone else has got any other questions. So is there any other key messages you'd like to put out while we're waiting? I think one of the key messages is always refer to sorry about this, Carolyn, but always refer to a diabetes educator, because they're really very good at conducting the orchestra and keeping people in line. Is that right? And reminding people about the routine checks they need to do, and diet, and kind of those types of things.
They are absolutely key to anybody living with type 1 diabetes, to help make sure that they are looking after things well, that things aren't being missed, that they are, those refreshers are really very important. We give so much information to people when they're first diagnosed, and then if they never come back and see an educator again, they will have forgotten at least half, if not more, of what's happened. And things change, and there's so many advances at the moment in type 1 diabetes management that we are able to provide. But absolutely, the whole team is important. Ideally everyone with type 1 should be linked in with a diabetes service, so that's an endocrinologist, a diabetes educator, a dietitian, as well as having their own podiatrist that they see regularly, and optometrists and so on. But just to make sure that they really have a good care team around them is important.
Yeah.
And I think my big message, I guess, as well, on top of all the other things we've talked about, is just that this is one of those absolute marathon conditions to live with. It does not go away. You live with it for forever, and there will be periods in everybody's life where it's too hard, and there are other things that get in the way, and that's okay. And it's important to be able to reassure your patients during that time that, they've got something else going on. There's multiple other stressors, or some mental health issues, or any other thing that the diabetes can take the back seat. They just have to stay alive and out of hospital, and then we can catch up on the rest of it later. It is really, it is a very big thing to live with. As I said, there's so many decisions that you have to make each day, that there are periods of time in life where it's okay to not be perfect, and it's important to give our patients permission to not be perfect.
I think that's a good message. Yeah. Yeah. Well, we might wrap it up. So just thank you both so much for your very clear and no frills messages tonight. And I think that's really what GPs appreciate. And just a reminder that there is going to be type 2 diabetes is getting its turn on the 4th of December, A to Z of type 2 diabetes medications, when to start insulin, different options. And Kristine and Carolyn have very kindly offered to present on that night as well. So please register for that. And we'll put up the recordings of the diabetes webinars on the Capital Health Network YouTube page. So they'll be up there in a couple of weeks. And please remember to fill in the evaluation surveys, and we'll send you out a certificate of attendance. But thank you both very much, and good night.
Thanks, Bob.
Thanks.
Thank you.
Thank you.